It's my pleasure to introduce Dr. Stewart.
It's not very often I get to lift the microphone up, so take this opportunity. Thank you, and thank you for the introduction, and thank you all for coming out, and to the organizers for asking me to come and speak with you. I was putting this talk together about 1 a.m. Last night. Not quite true, I had it, but I was doing some tweaks and I realized that there's not a lot of slides here, so I don't want to take a full hour to go through a lot of things. What I thought I would do, and I think the key to what I want to talk about to you today is, let's talk about some of the key issues. What are the symptoms? What are the features? What are the reasons we use medications? What problems might we expect? And as you can tell from Dr. Jog's presentation first, it's impossible. It's absolutely impossible to discuss all the nuances of Parkinson's and management in an hour or a day or a few weeks. I gave a talk last night in Toronto, and I think I spoke for about 2.5 hours without stopping. Well, I did stop because I had soup. And during that, I just kept talking and talking, and I realized it was to family doctors. They were asking questions about Parkinson's. And I realized that knowing that I was coming here to do this, it's really kind of daunting to try to cover everything. So rather than try to be exhaustive and say that I've covered every possible symptom, every possible complication, every nuance, I think what we want to do is get the broad overview, and that's why I've called this a brief overview, about what we do and why we do these things with medications that we use to treat Parkinson's. And hopefully that will elucidate some issues for you and clarify things. And because I'm not going to speak for 59 minutes and 57 seconds, I hope that we'll be able to have some chance for interaction and questions that may clarify other things that are of importance to you. So, without further ado, I will move on. We have to do this in a two-handed fashion so that I can see what I'm talking about and you can as well. Just a brief overview, you know this. Parkinson's disease is a common neurological disorder, one of the most common neurological disorders. Roughly 100,000 Canadians, perhaps a bit more, or perhaps a bit less, depending on how you look at the statistics. It is unfortunately a disease that progresses, and we can't yet cure that. Of course, that's a goal. The principal problem for the big features we see, slowness, stiffness, tremor, is loss of dopamine. And that dopamine is what we try to fix. There are other neurotransmitters, other chemicals that are involved in different aspects of neurologic function that are also affected to a greater or lesser degree in individuals, and those are also targets for treatment and rationale for treatment in other presenting symptoms. In terms of causes, this is a question that's often asked. What are the causes? Well, it is a combination of genetics, your environmental exposure, and time. So as we age, our genetics and environment influence one another, and we may see the development or expression of Parkinson's disease in an individual. It's kind of a weird way of referring to it because you have to wonder, well, what else could there possibly be? But that's what it is. It's the genetics and your environment and time. The disease that we call Parkinson's was first described by James Parkinson in what was called an essay on the shaking palsy in 1817. But this isn't as though prior to 1817 we didn't have Parkinson's. We certainly did as a species, as a group of humans. It's been described in other areas and alluded to in literature and in Shakespeare, for example. But the thing that we now call Parkinson's disease that bears his name, his eponym, was described first in 1817. I want to put this up because I like brains. I've spent a lot of my life dealing with brains, and this is nice. It's a brain. My favorite thing, I believe that every other organ that we have is some kind of stupid filter or pump, and what does it really matter? It's just, there's nothing more complicated and more fun than the brain. So this is showing a side view, if you will, with a little bit of cutaway to demonstrate what we're talking about when we say that there are problems in the brain involving several different types of neurotransmitters. And what we're looking at on this slide, and I can't point to it as Dr. Jog pointed out, we're looking at cutaway so you can see the brainstem, and you'll see an area down there where it says substantia nigra, and in the box there it says substantia nigra detail. don't worry about that so much, but just look at the line that's pointing to substantia nigra. If this projects well enough, I hope it does. Looks okay. All right. Maybe really at the back you might have trouble. The principal dopamine loss that we see that gives tremor, slowness, stiffness of movement happens because that area, substantia nigra, deteriorates. And it deteriorates in such a way that the pathways that it normally formed up to an area called the striatum is impaired in function. And that striatum is a kind of relay station, if you will, for the transfer of information between your cortex and your limbs. So the decision to, I need to get up and move, walk over here, that's where the interplay happens between the substantia nigra to the striatum to the cortex back to outflow paths in the brain. Obviously, it's more complicated than that, or we wouldn't have neuroanatomy courses lasting years, but that's the basic idea. So when we get this idea that we're talking about a problem in the brain stem or a problem with these neurons, this is what we're talking about in terms of the dopaminergic stuff. Now, also listed in there is something called the raphe nuclei and the locus coeruleus, and those are actually principal brainstem structures involved in different neurotransmitters. In the case of the raphe, well-known neurochemical called serotonin, and in the case of locus coeruleus, noradrenaline. So those are important neurotransmitter pathways that are involved in a lot of things. As I said, we could spend about 2.5 hours just going over this, but I have fear for your napping skills, so I'm not going to do that. We also know, and I'm sure everybody here is well aware of what the cardinal clinical features are of Parkinson's disease, but I like to put this up, one, to talk about the motor stuff, and then two, to talk about what I'm going to spend a little more time talking about today, and that's the non-motor things. So the classic things are tremor, but remember that 33% of people with Parkinson's will never have tremor. So it doesn't have to be tremor as a symptom that you have. Slowness, or bradykinesia. We like to turn things into Latin phrases, brady meaning slow, kinesia meaning movement. Wow, slowness of movement. Couldn't we have just said that? Yeah, we could have. And rigidity, or stiffness of movement. And then some people do have postural instability. That tends to occur later in the course of Parkinson's, but sometimes we see early features of that. So I'm not going to talk much about those features because they're kind of classic, although we'll get to them when we talk about drugs and why we use drugs. What I'm going to spend a little more time on the following four things, the non-motor symptoms of Parkinson's. And I was here for Dr. Jog's talk when he mentioned that it used to be, and not all that long ago, that you would go see a neurologist and all that we would talk about is how slow are you, what's your tremor like, can you walk? And we would ignore everything else. We don't do that anymore. The non-motor features are well known to cause a great deal of trouble for people with this disorder, and we need to address those things and treat them. So this is not something that we just, oh yeah, by the way, it's one of the things that we do want to elicit in a history and on exam, and every time you come in, are there problems in these areas? So let's talk about these in order, okay? We'll go to here and there, and let's talk about that one. So the autonomic nervous system, we couldn't have this without being a little more complicated. So we have a central nervous system, that's brain and spinal cord. We have a peripheral nervous system, that's all the nerves that come off the spine at different levels. Then we have a third component called the autonomic nervous system, and that's made up of parts from the brainstem and parts in the lower part of the spine. And the autonomic nervous system is one of these sort of caretaker kinds of systems that takes care of a lot of things, automatically or autonomically, so that we don't have to think about them or pay attention or have nervous system capacity taken up, if you will, bandwidth taken up looking after this. When you have autonomic nervous system dysfunction, a lot of things can happen. Blood pressure can be a problem. It can go down, and a lot of people have what's called postural hypotension that reflects some autonomic dysfunction. There can be problems with heart rate, and if you were following along with my earlier pedantic explanation, you would call that bradycardia for slow heart. So problems with heart rate, it can go down. You can get rapid heart rates. There are problems with control of urinary function, so you have irritability, multiple trips, incomplete bladder emptying. There are, of course, problems with constipation, and that is an interplay between the disease process affecting autonomic functions and the medications. Bit of a hard thing to deal with. I said last night when we were talking about this that there are a lot of rocky, hard places in dealing with Parkinson's. Lots of times you're caught between a rock and a hard place. And of course, impaired sexual function is another autonomic thing. Because of some of these effects that the autonomic nervous system has on the gut, people have reduced appetite. They feel full early. They may have bloating. They may have gas, abdominal pain, constipation, of course. And those are changes that are problematic. And of course, the other issue that I always like to point out in this regard when we talk about this type of thing, why people lose weight with Parkinson's, why people have poor appetite with Parkinson's, you also have impaired sense of smell in a lot of cases. And the impaired sense of smell actually contributes quite a lot to our appreciation of food. So if you don't have those appreciation of odors, foods all taste like wallpaper paste. So it's not very appealing. And it's the pathology that happens as part of this disease process in the autonomic nervous system that can contribute to all these issues. You have to remind me to press both things because I can't do those things twice. Two things at once. So non-motor symptoms, mood and psychiatric symptoms. Another very big area of impact. Very common to see depression. Depression can be early or it can be late in Parkinson's, but depression, anxiety, even some psychiatric features like paranoia, hallucinations, delusions. Because Parkinson's, as I said, affects other neurochemicals besides dopamine for movement, noradrenaline, serotonin, adrenaline, some others. Because of that effect on the pathology of Parkinson's on these neurochemicals, we can see these problems. And as I said, mood, anxiety tends to be early, but you can see it all through the course of disease. Paranoia, agitation, hallucinations are usually later. And they're often an interplay, again, an interplay between medications, disease progression, and other problems and health problems that can arise because of Parkinson's. Remember, we don't operate in a vacuum. We are in our space and time and function. So if you are not moving very well and not able to clear your lungs very well, you may be more susceptible to a cold or a flu or a pneumonia, and that will affect your response to medications. There's lots of complicated interactions that make everything much more difficult than you'd originally think. I believe this should say cognitive and memory deficits if I've been able to keep my mind on two things. Cognitive and memory problems, also another comorbidity, if you will, another thing that happens with Parkinson's. Difficulty concentrating, problems with speaking and memory, problems with reasoning and planning, problems with navigation and driving. These can be issues. I had a question last night about what do we do about driving with Parkinson's? And that's a very complicated issue. It's not one that you can just say, oh, well, here's what you do, X. There's no simple answer to that. And it's a complicated issue with a lot of factors. And again, these problems are all thought to be due to changes in function and integrity of different neurochemical systems. In the case of memory and cognitive, we think of a couple of neurotransmitters, acetylcholine, glycine, glutamate, an inhibitory neurotransmitter known as gamma-aminobutyric acid, or GABA. So all of these neurochemicals are involved, right? I think that's the basic message I want to keep hammering away at. It's not just, well, I've got this problem with slowness and stiffness and maybe tremor, and you want to replace that and everything else is okay. It's not. It's affected, and it has implications. A lot of people complain of pain and sensory changes, and even as, well, I'd like to think as recently as when I started, but it is a long time ago now. But when I started work, we didn't really think of pain and sensory problems as a manifestation of Parkinson's problems. And true enough, it's not really a core symptom. It's certainly not a presenting symptom. Somebody doesn't come to you and say, well, I have some pain and numbness, and you think, oh yes, that must be Parkinson's. That's not it. But we do know that in the setting of Parkinson's, people can have pain and sensory problems, abdominal pain, limb pain, muscle spasms, limb contractures, abnormal postures, numbness, tingling, or burning. And these are things we often see in the context of we're treating you for some things, and as these medications wear off, we see these problems. And I've just put up here the partial list of some of the things that we can think of as non-motor wearing off symptoms. So when the medications wear off, what do people report? And roughly you can divide that up into these categories: sensory, psychiatric, and autonomic. So pain, tingling, sensory loss. Akathisia is another one of these great words, just means restlessness and fatigue. And anxiety, depression, panic, cognitive changes. So some people will say when their medications are on, when they're doing well with their medications, they're crisp in thinking. And when their medications are off, they have trouble concentrating and can't formulate thoughts well. And of course, all these other autonomic features: drooling, swallowing problems, belching, abdominal bloating, urinary frequency, sweating. This has been interesting because, as I say, 15 years ago, we used to just say, okay, the motor symptoms and mood, okay, we get that. But we didn't really understand these non-motor wearing off features very well. And after a while, we started recognizing, oh my goodness, almost anything that people can complain of could be a manifestation of wearing off. So think about it. And it's one of the ways we kind of approach, do we need to change your medications? Do we need to do something more? It depends on what kinds of problems you're talking about. So let's go on to pharmacotherapy. We're going to look at using medications to address specific problems. You kind of already know this stuff, so that's why I say this isn't really a very detailed, complicated lecture. It's really talking about stuff you already know, but the rationale and how things fit and why we would do certain things with medications. So let's talk about, I've just gone through the medications in class order, so just different classes of medications. The first one I put up here is the MAO-B inhibitors. This, for those of you keeping score at home, stands for monoamine oxidase type B. So if you see a type B or something like that in medicine, you got to pretty much imagine there's a type A, and there is. Monoamine oxidase type A works on different amines, monoamine oxidase. Type B works in a slightly different way. We have two drugs that are important in Parkinson's management with respect to monoamine oxidase type B inhibition. And those two drugs are rasagiline or Azilect and selegiline, a drug that goes by a couple of different names. There are some important, interesting overlaps and some important differences between these two drugs, and we'll talk a little bit about that as we go along. Just introducing the categories here, and we'll talk about their use and issues. As Dr. Jog alluded to, we have dopamine agonists, and an agonist just means it acts in the same way as. So a dopamine agonist drug is one that works kind of like our normal dopamine. And we have 3 on the market right now. A few years ago, many years ago actually, we used to have more. But some of those drugs had some important medical complications that made them unworthy of continuance. So we only have 3 drugs now that we use in this category. We have Requip. And what I've tried to do with all these medications is put not only the trade name, but also the drug name. And that's important because you're going to run across that drug name when you fill a prescription. Now, the way it works in Ontario and other places is if I write a prescription that says Requip and whatever the dose is, the pharmacy can give you a generic version of that drug that will bear the drug name, ropinirole. And then there's usually a prefix or a suffix that will indicate which company made that generic. So that's why lots of people get kind of confused. There's all these different names and it's not clear, what the heck am I on? You said Cinemet, I'm taking Levocarb, what the hell? So it's a confusion I like to try to clarify. So Requip, otherwise known as ropinirole, is one of these agonists, Mirapex or pramipexole, and Nupro or Retigotine. And Nupro, as Dr. Jog mentioned, is a patch. It was out on the market in Canada for a while, but the drug didn't seem to play well with the adhesive, and the patches kept falling apart and crumbling. So they had to take it off the market for a while and rejig it all and make it work, and now it's working better, and we've got it back on the market now for about a year. The gold standard, and one of the last questions that Dr. Jog answered is specifically to this point. The gold standard, meaning the best medication we have to treat Parkinson's pure or core motor symptoms, is levodopa. And levodopa is a levodopa preparation. So levodopa is the drug that we want to deliver to your brain to have your brain turn into dopamine. See where we're going with this? So in order to get the right amount of levodopa in your brain and not in your gut, which can make you throw up and cause a lot of other troubles, we combine in a preparation levodopa with some peripheral enzyme inhibitor. In the case of Cinemet, or Levocarb as it's popularly called in most of the generics, levodopa is paired with another compound called carbidopa, and that's why your drug is 100/25 or 250/50 or 100/10, whatever it is. The common one that most of us use in the movement disorder world is the 100/25 dose. And until one of the companies decided to screw us all up and make it very difficult, it was a yellow oval pill. Now, if you get the brand name, it's not a yellow oval pill anymore, and it's a bit confusing. But back in the old days when it was easy, that's what we had. There's another preparation of levodopa that some people may be on. This is a preparation that actually contains a different other drug to inhibit peripheral conversion of levodopa. It's called benzerazide, and that trade name is Prolopa. And I don't know, is there a generic? Do you know, Jeremy? I don't know if there's a generic to Prolopa, quite honestly. It's not a drug that we use very often, or at least I don't. Some people do, some people like it. There's variations in what you get used to and what you like. I will use Prolopa if somebody has a problem with Sinemet or levocarb. So if they can't tolerate the carbidopa, some people's enzyme systems don't work well. They may not tolerate the carbidopa, so we'll switch to Prolopa. And again, I don't think you can overestimate or overstate the case that levodopa is absolutely the best drug we have to control symptoms. There's another enzyme. There's lots of enzymes. But there's another enzyme of importance clinically, and that is an enzyme known as COMT, which stands for, are you ready to stay asleep for a few more minutes? Catechol-O-methyltransferase. And that enzyme, if you inhibit that enzyme, you also improve the delivery of levodopa to the brain. So sometimes we'll inhibit not only the enzyme that's involved with carbidopa or benzerazide, AAA decarboxylase, we will also try to inhibit the COMT enzyme to try to be more smooth in the delivery of levodopa to the brain. Comtan is the trade name of the one that's on the market now. Its drug name is entacapone, and it's recently gone generic. We used to have a drug called tolcapone. We called these the Capone families, the entacapone, tolcapone. We don't have an Al Capone, but just so you know. But we used to have tolcapone. It was called Tasmar. Very good drug, much more potent than Comtan, but it had some liver failure issues, so it was withdrawn from the market. You can still get it if you apply for special access. It still can be used on special request, but it's not one that I bother with, really. We have one available, it's safe, it works. Dr. Jog also mentioned that he uses a drug called Stalevo, and Stalevo is simply the combination of Sinemet or levocarb, so levodopa plus carbidopa plus entacapone. And all that does is just increase the efficiency of delivering a drug. So instead of taking one of these and half of these and one of these, you take one Stalevo pill. And you can get a dose that you need, a specific targeted dose. Okay, so again, I want to say this is a gold standard therapy, levodopa and decarboxylase inhibitors. It's levodopa is the prodrug of the drug dopamine, so we administer the prodrug, your enzymes in your brain turn it into dopamine and release it. There are several versions. We have Sinemet, we have the generic names as mentioned, we have Sinemet CR, and Sinemet CR is an interesting little thing. Sinemet CR stands for controlled release, and this was an attempt about, close to 20 years ago, I would guess, to try to make the drug last longer. We look at something in medicine and pharmacology, it's something called a half-life. So how long a drug lasts, how long it takes to get to half of its level. And the longer the half-life, the more drug that's around for any given amount of time. Sinemet, carbidopa, or levodopa carbidopa, or levocarb, Sinemet, has a very short half-life in the order of 2 hours, 2.5 hours. So it doesn't last very long. Sinemet CR was brought to the market to try to address that problem. Instead of having to take multiple doses, could we have you take something that lasts longer, a bigger dose and lasts longer? Good idea. It's a great idea, and we're still working on that concept. Unfortunately, Sinemet CR hasn't really delivered on that very well. It turns out that the formulation for that pill, and this isn't true of everybody, of course, but it turns out that the formulation of the CR pill itself doesn't always break down the way you want it to. So you may have, for example, no effect of the drug at all. And the drug can be passed essentially whole all the way through the whole process of your gut. That's not efficient, not very good, not a great idea. So it's led me to call this, in my own way, Sinemet CR I refer to as capricious release rather than controlled release, as it doesn't do what you think it does all the time. Two things I've already mentioned here. Prolopa is the other version, levodopa benzerazide. And Dr. Jog mentioned duodopa. I think duodopa is an interesting thing. I won't belabor the point. He talked about it, how it works, and we can get approval. It's quite an expensive option. You have to be the right patient. It involves a tube in your gut. It's not easy. And you really do have to have somebody who has a lot of experience with handling those tubes and managing them to avoid blockage and complications, not beyond the expense. I think the thing for me that is hopeful about duodopa is that it illustrates that if we can figure out a way to deliver this drug in a more efficient way than we're using right now with oral, we may get a better response in treatment. And that's very encouraging because duodopa has some great data showing that people who have severe dyskinesias, the extra writhing movements, that's a complication of too much levodopa at any one time, that duodopa can really effectively reduce those problems and make movements smooth. So I think the concept that we can deliver a drug, and if we can figure out a way to make it release in a smooth fashion, is very hopeful. And there are some drugs in trial right now. Dr. Jog mentioned the aerosolized version. That's not really controlled release, but the idea of delivering drugs in a different way to see if we can improve functionality with the medications is very hopeful. So the duodopa may be more of a prototype way rather than an actual target for what we want to do. And I don't know if Dr. Jog mentioned this, and I apologize if I'm repeating, but when we talk about expensive, we're talking about $50,000 to $70,000 a year for this drug. Okay? So that's pretty expensive when you compare it to, and everybody knows what it costs to buy generic Sinemet. Right? So it's an important thing. Okay. Now, going on to some of the other drugs that we use, we've been talking about levodopa and the most important one, yes, but there are other drugs, and we use them for different reasons. So there are drugs that we call cholinergic agents. These are drugs artane, also known as trihexyphenidyl, cogentin or benztropine, chemidrin or procyclidine. And these are all drugs that can be helpful. They're particularly helpful for tremor, and we'll get to that in a little bit. As you can tell, I just love the nice big biochemical stuff. So N-methyl D-aspartate antagonist. Doesn't have a great rhyme to it? It rolls off your tongue. It's fantastic. The drug we use in this class for Parkinson's is amantadine, and some of you may be experienced with amantadine. We often use that to treat the excess movements, to treat dyskinesias. It can be used early on in Parkinson's by itself. It's effective. It can help a little bit in some situations. Exactly how it works, not sure. It acts on this system called N-methyl D-aspartate, which is an excitatory neurotransmitter pathway. We don't really know why it works, but it does. As with a lot of drugs in medicine, it has an interesting history. This was actually a drug that can be used to treat flu symptoms or prevent flu. And when it was being tried, some of the people in the trial had Parkinson's, and they said, hey, I'm doing better. I don't know about my flu, but my symptoms are better. So it started being used to treat Parkinson's core symptoms that way. There's some new compounds. I'm only going to mention this. There's some other things pipeline-wise, but new compounds. We've had this, a drug called adenosine 2A receptor antagonist. There's one called praladinant. It's in trial, one called safinamide. They've been in trial for quite a long time, and there's some issues with them as to whether or not they deliver what we want. So are they useful? Are they helpful? Are they safe? Are they effective? And are they reasonable to use? They've been around under study for quite a while. And by quite a while, I mean at least 7 years since I was last asked to do, or rather 8 years since I was first asked to do a study with one of these compounds, to last year or so where I was most recently asked to do a study with one of these drugs. So they're out there, and there's some work being done, but we're not too much closer to launch. Neuroprotection, this deserves a mention. I had a fellow yesterday in my office who is in his 70s, and he said, I don't want to take these pills anymore, I just want a cure. And I get that. I understand that. I wish we had something of that nature, but we don't. And you know, we can say there's lots of research being done, and there is a heck of a lot of research being done, believe me, around the world, all over the place, in multiple large labs, tons of work being done. And, you know, all I can say about that is, yes, we would like that. It is more unfortunately, it's more complicated than you think. It's not so easy to just, okay, fix that. That's why I say the brain's the most important thing. Everything else, you can, you know, fix it. You got artery problems in your heart? Jump a tube, works fine. You got kidney problems? Yeah, put in another one. That's not so bad. We can't do that with our brain, so it's not as easy. Now, we would like to find a medication. If we can identify the pathology, what's going on, we know a lot about pathology in Parkinson's, we can identify when that starts or how it takes place. Can we give you something that modifies the course? So instead of doing this, we slow you down. We don't have anything like that yet on the market. Unfortunately, many drugs have been looked at in that context to try to do different things to show that effect. It's very difficult to show that effect. And so as a result, we have no convincing evidence that anything will do that. Lots of research. There's, as I mentioned, different versions of levodopa preparations, things that may provide a longer release, a better release point, and that sort of thing. So there's lots of stuff happening. So I've alluded to some of this, and that's why I think there's a bit of overlap, but I sometimes think overlap's not a bad thing. If you hear the information from 2 or 3 different angles, it tends to make a little bit more sense. I hope you agree, and don't throw things at me if it sounds too repetitive. So medications, what are the effects and possible side effects of different medications? Okay. I think you get the picture, I would think, from what I've said so far. We select medications to correct an underlying problem. So there's an underlying neurochemical problem, we identify that problem, we select from the toolbox of medications that we have to try to correct that underlying problem and see if we can improve clinical function. Very simple terms, dopamine. Dopamine causes slowness, stiffness, tremor, so we try to replace that to improve slowness, stiffness, and tremor. Noradrenaline and serotonin are involved in mood and anxiety. If those are low, if those are impaired, if those are not functioning properly, we replace those to try to improve. We use acetylcholine-based drugs for memory and cognition. And there are other medications used to treat the side effects that occur from that treatment. So we can use things to counter effects. Again, this is why I said I can't cover everything. So yeah, I understand. Lots of people have constipation, and there's 63 different ways of approaching constipation. I found a nice little thing called a constipation protocol. And I tend to print that out and give it out. So it has lots of different things you can try, fluid and fiber and different combinations of things and techniques and tricks to see if we can help with the constipation. But in terms of going over all of those drugs, it's not very fruitful, if you will, in this kind of a setting. So let's look at each issue in more detail. The mobility problem, slowness and stiffness and resting tremor, the major motor feature. It's a dopamine deficiency thing, so we use drugs with a dopamine action. We use Sinemet, Prolopis, Stalevo, Duodopa. We use the dopamine agonists, ropinirole, pramipexole, rotigotine. We use the monoamine oxidase type B inhibitors. And I used to have a slide that showed like a prototypical neuron and where all these things work, but you know what? It doesn't project well. And after seeing what happened last talk, I thought, we'll leave it out. It doesn't project very well, and it's hard to follow. So basically the idea is dopamine problem. What drugs do I have? What drugs in my toolkit can I select to address that issue? These are the ones. And in the right person, the right circumstance, we may use one or both or all 3 classes of drugs. We may use one, then another. We may have one followed for a long time, add another. We may subtract one. There's all sorts of things that you can do with this. The one thing that I tell people when they're learning about Parkinson's management is I see residents and students and so on that come to my office, and I tell people that if you're the kind of person who just likes to follow a recipe, step 1, step 2, step 3, don't treat this problem. Because step 1 is, well, you could do all sorts of things. Step 2 is you could do all sorts of other things. So there's no good steps, and you need to be able to be flexible and try different things. The concept, of course, is we expect this treatment to help improve slowness and stiffness. We're never good at treating tremor. We are terrible at treating tremor with medication. It doesn't respond well. And the medications that do help for tremor tend to cause a lot of other irritating side effects. So drugs that I mentioned that we can use for tremor, I mentioned Artane, I mentioned Cogentin, I mentioned procyclidine. Those types of drugs, they may help tremor a little bit, but they can also give you dry mouth, dry eyes, drowsiness, cognitive problems, ankle swelling. Not so great, and maybe the trade-off isn't worth it. And a lot of times we have to deal with that, the trade-off. Depression and anxiety, mood problems, very common. What are the numbers? Well, we say, roughly speaking, 50 to 75% of people with Parkinson's disease will have these issues at some point. It may occur early, it may be late, maybe throughout the course of the disease. It may be a predominating feature in some people. And I've seen a number of patients where, yes, they have Parkinson's, and yes, they have the clinical features, and yes, that responds to medications, but their overriding problem is not necessarily those core motor features, but the anxiety. And that's just part of the neurochemistry and how it varies. Again, last night somebody asked me about whether we see Parkinson's disease as a discrete disorder or whether it's a spectrum. And I think of it as a spectrum. And all that really means is there are different manifestations for every given individual. And that means that every individual has to be treated as their own case. You can't say, this is what we do for everybody. And that's makes it complicated, but it also makes it interesting to try to help, to address what problems and what things work for that person. There's different classes of drugs we use, SSRIs, SNRIs, and tricyclics. I honestly have to say, I put in tricyclics here, but I almost never use this class of drugs for treating Parkinson's depression or anxiety. And Dr. Jog had mentioned that. Actually, I was pleased to hear him say that because it comes up in all of the data review. Oh, yes, this is an effective drug. This is an effective drug. But when you ask all my colleagues, nobody used them. So I don't know how effective it can be if none of us are using them. But it keeps showing up in all these data reviews from around the world. I don't like them. They have a lot of bad side effects. They give a lot of trouble, and they're not well tolerated. I do use drugs like Celexa, and again, here's the trade name, not trade name. Dr. Jog mentioned these as well. Mirtazapine or Remeron, one of my favorites. Sleep disturbance is a big issue in Parkinson's, and this can help with that. It may even help with tremor a little bit, so it's worth trying. So I use a lot of Celexa, a lot of Mirtazapine. Occasionally, and more recently, I've been using Cymbalta, again, partly because it has some effect on pain and may be helpful for people who have some pain issues. I do use Paxil occasionally. I'll use Trazodone on occasion. And once in a while, I'll use a tricyclic, and one of the tricyclic drugs here that I've listed is nortriptyline. So these are the classic core drugs that I would use to treat those symptoms. Yep, went the wrong way. Knew that was going to happen. Cognition and memory. If you will, this is a deficiency in acetylcholine. When we look at a different condition, Alzheimer's disease, one of the principal neurotransmitter deficits in Alzheimer's disease is a loss of acetylcholine, or what are called cholinergic projections. I spent a lot of many more years than I'd like to admit, working on the cholinergic projections from an area of the brain called the nucleus basalis of Maynard. How's that for trivia? That's like a conversation starter right there. Hey, let's talk about that nucleus basalis of Maynard. Not. That pathway, though, an acetylcholine pathway, seems to be important for maintenance of and driving of cognitive function, memory and alertness and attention and planning. And we do have some medications that we have borrowed from the Alzheimer's world to treat this deficiency. We have 3/4, and I'll explain what I mean. And yes, that's actually a good way to refer to it. We have a drug called Exelon. Exelon, the trade name is Exelon, the drug name is rivastigmine, and rivastigmine has the most clinical trial and experimental data in the Parkinson's patient, and it's shown to be effective. If you can tolerate it, because about 16% of people have terrible nausea with this, and it's not well tolerated. And as many of you know, some of the other drugs also give you nausea, so add insult to injury, and it's not well tolerated. There is a patch version of Exelon. Patch version of Exelon is much better tolerated. Unfortunately, it's not covered by OHIP. If you have private coverage, it can be utilized in that way, but it tends to be a bit expensive if you're paying on your own, and that's a barrier. The only other thing that I will say about this in a slightly humorous fashion is if you are on the Exelon patch, remember to take the old one off before you put the new one on. You can't paper yourself with these things. Not a good idea. That actually happened in a clinical trial. Patient showed up and they were showing signs of toxicity, and the nurse practitioner, the study nurse, took their shirt off and was like, patches everywhere. Okay, those got to come off. You got one at a time. So And I always tell people that story when we talk about using a patch, whether it's the dopamine agonist patch that's fairly new, is I say, okay, the first thing you have to do is make sure you press on that patch and hold it in place for 30 seconds, and then the next most important thing you have to remember is the next day, take that one off, put a new one on the other side. So that's it. Aricept was the first drug on the market to treat Alzheimer's symptoms. So we borrowed that one too. It doesn't have as much data, meaning we don't have enough clinical trials or as many robust clinical trials where it's been used in Parkinson. But we know it's a class. It's the same class as rivastigmine. They both work pretty well. They both can be used. And in fact, I use them. So the person who says, I don't have a private drug plan, I can't afford the patch, and I can't tolerate the Exelon or rivastigmine because of nausea, I'll try Aricept. And then the third one there that I'll list is called Remenil. Drug name is galantamine. And galantamine is a once a day. It comes in an extended release version, works reasonably well. However, there has been some data recently that shows that Remenil may actually increase the risk of falls in Parkinson's. So it's not one of my favorites. And it's one of the drugs that I look at and say, okay, well, we can't use that. Particularly, in fact, I saw somebody, I think it was last week, with falls, and I looked at their meds and went, oh crap, they're on Remenil, we got to get that off. Whether that's entirely the cause or not, it's not clear, but we know it's associated with an increased risk, you have to remove it. And that person had actually failed Exelon for the reasons I mentioned, nausea, couldn't tolerate it, failed Aricept, didn't like it, we tried Remenil, can't use it now. Now, this is where I said there's a /4th drug on the market, and the drug that's on there is called Ebixa or memantine. And remember I said amantadine is of a class of drugs, everybody remembered that, wrote it down because they loved it, N-methyl-D-aspartate antagonist. Memantine also has an N-methyl-D-aspartate antagonistic action, not its principal action, but it does have that. And Ebixa is used as an adjunct in Alzheimer's. So if people are on one of the first-line drugs and failing, then we'll add Ebixa and see if we can get any benefit. We do the same thing in Parkinson's. I must say, unfortunately, I have not seen a great deal of success with this. It wouldn't be one of those ones where I'd say, oh, we must have you on this medication, it's excellent. Haven't seen that. I've tried it a few times because of its relationship to that other drug, amantadine, in the action NMDA. I've tried it for dyskinesias. Just doesn't seem to work at all. Everybody's different, so sometimes you can try it and maybe you'll get a response. So I never say never to these things. I never say never. Yeah. How many double negatives? So those are some of the drugs we use for that. And some guiding points I want to talk about. Sometimes some medications are used to treat problems that arise from something else. So if a problem arises because you're using one medication, we may add something else. A classic example would be, you've already got some constipation, we put you on doses of Sinemet, the constipation gets worse, we start to add something else. Maybe without the Sinemet, you were able to cope with the, constipation and manage, but when we added or increased the Sinemet, that got unbearable. So we may have to add something else to deal with it. And there's an interaction. It's an important interaction, again, alluded to by the last question that was asked of Dr. Jog. There's an interaction between the medication and the disease process itself. This is not a static thing. It's not as though we say, okay, here you got diagnosed with Parkinson's, now nothing will change from here on. That's not what happens. We know the disease continues to change your brain chemistry, your physiology, and we have to respond to that. So when we give certain medications, as you are taking these medications to replace or deal with one problem, you're also changing. The landscape is changing. We have to constantly adjust what we do, either with more medication, more of one medication, different types of medications, different combinations, maybe taking away a medication we started with because it's no longer viable in the circumstance. And of course, sometimes it's inevitable. Some medications do have side effects, and treatment is always a balance between these competing and complementary issues. I always tell people, some of you who have seen me, I may have said this to you, that if you can show me, or if we can design a medication with no side effects, I will spring for the business class ticket to Stockholm to get our Nobel Prize. If we can come up with one without a side effect, I'll pay. It isn't out there. Everything can cause a problem. And of course, I'll go on to that, I think, from this idea is that every possible medication we have has the potential or the possibility of causing side effects. There's no such thing as a drug that won't, and you can't tell yet, looking across the desk at your patient, whether this person or this person will have a problem with this medication or that medication. No idea. Now, we may get to that stage at some point in the future with something called pharmacogenomics, where we'd be able to analyze your genetic structure and understand the complications and the interaction between genetics and drug, but we're not there yet. Lots of cool work being done in that, but we're not there. But the other thing that I want to point out to somebody is, if I tell you a potential side effect, it's not an inevitability. So not everybody develops side effects. In fact, almost everybody doesn't develop side effects. It's the smaller number of people who develop problems as a result of a medication. The risk-benefit's the key trade-off when we're trying to do this. And depending on what we're using, we can expect or predict what might be some problems. So drugs that can cause dry mouth, well, I can predict that you're going to complain of dry mouth if that's something that it's likely to do. Not very hard to make these things. So I want to talk a bit about side effects, and then I'm really almost done because I'm almost out of time, which is surprising because I didn't think I'd have that much to say. Ha! That's fun. Okay, so medication side effects. We know about these drugs, the dopamine drugs, levodopa, dopamine agonists, even MAOBs. But not so much MAOBs, actually. Let me leave that off. The common side effects of these drugs, and this is something that I print out when I start somebody on these medications. I print out a sheet that says, here are the common side effects. Doesn't mean you're going to get them, it just means it's possible. The common side effects: nausea, lightheadedness, rarely hallucinations, sometimes ankle swelling, increased constipation, fatigue, drowsiness, sleep disorders, confusion. Anybody ever watch those ads from the States on drugs? You watch those things like, oh my God, I'm never taking that ever. It sounds that way. But then you have to remember that what we're talking about is a teeny tiny slice of people have ever reported that. And I once did this little exercise. We used to get a book called the CPS. It's not in book form anymore because nobody has books anymore. Everything's on the computer. So we used to get these big books. They were called the CPS manual. And it was about this big, like this, thick. Big, thick book. And it was onion skin type paper with all drugs that we have on the Canadian market and all the potential side effects. And you can do this little trick. Take that book, throw it down on the desk, randomly open it to a page, close your eyes, touch a drug, read the side effects. Close the book up, write the side effects down. Close the book up, do it again. You'll get the same list. Every drug causes everything. Every drug has the potential for causing every side effect. So, drugs that I use to treat migraine, one of the listed side effects, migraine. Use drugs to treat depression. One of the side effects is depression. Well, could it be that they had depression and the drug wasn't working? So it's important to understand that when we see those lists, and particularly the lists you can get from pharmacies that can sometimes print out things, those are helpful things we need to know, we need to be aware. But it's important to understand what that means. It's not as though I'm going to put you on this drug and you will have this problem. Not at all. So those are the common side effects. What I've done with each of these things is I've kind of broken them down the same. So what the drug is, what the common problems are, and what's related to disease progression, because levodopa, an important disease progression-related complication or side effect of levodopa drugs, and to a lesser extent dopamine agonists, are dyskinesias. That's the twisting, writhing, turning. And sometimes this is confused with tremor. So people will often call my office and leave a message with my secretary and say, since he increased my medications, my tremor is terrible. And it's not tremor. It's not tremor. And I always look at that because I get the note, my secretary writes out a note, gives me the chart, I look at the chart and go, but they've never had tremor before. And about 18, 16 years ago when I first started doing things, I would think, oh my God, what's happening? And then I realized, oh, we have to get the definitions clear. So tremor is resting tremor, slow, 4 cycles per second, usually in one limb, can be in both, disappears mostly when you do things. Dyskinesias are, and I'm not embarrassed to do this, dyskinesias are this kind of movement, that you can see twisting and writhing. And when people are not sure, I say, have you ever seen Michael J. Fox not doing well on TV? That's dyskinesia. So dyskinesias are a complication of disease progression and medication. It's not just the medication, it's the disease progression plus the medication. But you need both. Other things that it can be related with dopamine drugs as disease progresses, hallucinations and delusions. That tends to be slightly more common for the dopamine agonists, but it does happen with the levodopa preparations as well, and something we always have to be aware of. Sometimes the hallucinations can be benign, not particularly bothersome. You recognize this isn't real, it's no big deal. Sometimes it can be more disturbing or troublesome. I always ask about them, always want to know about them. We have some ways of dealing with them, and again, since I can't be totally complete in all these things, there are some drugs that we use to treat complications that I haven't listed here. I've just listed the core symptom problem. Let me go back to one. Let's see. Let's make sure I wanted to say that. Okay, yes, so I kind of skipped over that because I went down to disease progression. I do want to say a word about impulse control disorders because these are important problems, so I'll do that here. We were involved, a lot of us in Canada were involved in a study called Dominion that was looking at this issue of impulse control disorders in Parkinson's patients, treated with, among other things, pramipexole or Mirapex. And what we did was we'd recognized, and it had been coming out in reports, that people who took these drugs sometimes had problems with certain activities that would get a little out of hand. And the classic 4 impulse control disorders that we asked about were pathologic gambling, compulsive buying, binge eating, and hypersexual behavior. So this study was designed to analyze. So we wanted to see everybody as they came in and ask standard questions. Do you have these problems? So we did that as part of this study called Dominion. And that was, I think I enrolled about 60 people in total. In North America, there's over 3,000 people were asked. And here are some results for that. We found that about 17% versus 6%, or 7% rather, of patients had impulse control disorders on a dopamine agonist. So 17% of patients on a dopamine agonist would have one or more of these pathological problems and behavior control problems. It wasn't confined to the agonists, although it was more common. We did see it in just about everything. We saw it in amantadine, we saw it in levodopa preparations, we saw it in some of the cholinergic drugs, but we have not yet seen it. I am not aware, I haven't looked lately, but I am not aware of any referral of an impulse control disorder in relation to the monoamine oxidase type B inhibitor. For whatever that's worth, we haven't seen it. So this is an important thing we have to tell people about. The tendency to do this, the potential for having an impulse control disorder of this sort, also tends to vary with your personality. So if you were a kind of person who had an impulse control type of personality or an obsessive compulsive type of person, that's been a tendency in your life, the risk is higher, closer to 25%. That's an important piece of history to ask before you put somebody on this type of medication. Have you had this tendency? No, I haven't had this tendency. What was interesting too in the study was how often caregivers and spouses were unaware of some of the problems. I had one patient come in who said, oh yeah, I have this problem, and the spouse said, no you don't. And the patient said, oh yes I do. And so it was a little interesting argument. I sat back for a while and watched. And the substance of the issue was overeating. And what would happen is the one individual would go shopping and buy 2 bags of chocolate chip cookies, one that was put in the cupboard and the other that was consumed. So the spouse would come and, let's have a couple of cookies. So the patient would have a couple of cookies with the spouse, already having had 36. So that's a minor thing. Now, there have been some bad ones where people have spent an awful lot of money, like all of their money, and lost everything because of the gambling issue. So it's interesting to hear about, but it is a severe impact, or can be a severe impact. Okay, so going on again, I think we're getting close and you're tired. Dopamine drugs like the monoamine oxidase type B inhibitors, I've separated them out. Actually, very few problems with this class of drugs, not a lot of trouble. Particularly Azilect, I haven't had trouble. When we use selegiline or Deprenyl, people do complain of appetite suppression, they complain of insomnia and sometimes hallucinations. That's not very common. Yes, it can, of course, happen with rasagiline, but it's not very common with Azilect. What I tell people about rasagiline is that it can cause mood problems. and anxiety problems. And that means you can get anxious, or you can also just get laid back. So you should also get depressed. So it can be high mood, normal mood, low. And the same thing with blood pressure. Blood pressure can go up a bit, or it can go down a bit. So I always ask people, just monitor your blood pressure, ask the caregiver or spouse, just let's keep an eye on this if you think there's a significant change in mood. And again, I had someone who started the medication, within 2 weeks was terribly depressed, felt horrible, carried on for a week, called my office. I said, stop. They stopped the drug, and 3 days later they were back to normal. It's very clear. It can happen. Worth paying attention to. Cholinergic drugs, I'll be quick. Artane, cogentin, amantadine. I put amantadine on chemidrin. Dry mouth, dry eyes, drowsiness, ankle swelling, rash. I've talked about that. Confusion, aggravates constipation, urinary retention. Things that are related to disease progression, hallucinations, and delusions. You see a common theme here that what will happen in a lot of cases is we start medication, we start another medication, we add one, we increase one, and then these problems develop. And we look at the drugs and go, okay, no more of that. Let's reduce that dose. Let's try something else. So we start medications up and then take them away depending on the problems. And usually what we end up on, no matter what we start, what we begin with, where we go, we end up on levodopa. I'll be very quick again about this. Mood and anxiety drugs, the common side effects are sweating, anxiety, weight gain, appetite stimulation. But hang on. Lots of people with Parkinson's lose weight, so that's maybe not a bad thing. It's not so bad in some situations where there's weight loss and poor appetite. We can stimulate appetite, increase weight. That may be a side effect we're looking for to utilize. Similarly, drowsiness. One of the drugs that Dr. Manderjog mentioned and that I've used a lot is mirtazapine. We've referred to it already, mirtazapine or Remeron. If people have sleep disturbance, that drug makes you sleepy. Fantastic. I'll use that side effect to my advantage if we need to. And again, common thing, disease progression, we can get into these hallucination issues. I'm almost done, I swear to God. I've already talked about these things, cognitive and memory drugs, what they are. The common ones, I've really referred to this already: nausea, appetite suppression, drowsiness, fatigue, hallucinations, delusions. And of course, the biggest problem with this class of drugs is they're really not that potent and they don't help that much. We try as much as we can with them and jack the dose up as much as we can, but it may not be enough. That's the biggest side effect, I guess, in a sense, is that it just fails. So in conclusion, you're glad to hear, all medications can cause side effects. Only some people ever experience those side effects. The risks and benefits have to be balanced, and the illness itself complicates our treatment over time. It's not a stable landscape. It's a moving target. We have to adjust how we approach it. And all our symptomatic treatments are pretty good, but they're not perfect. We can do pretty well with controlling motor symptoms for a pretty good time. We can do pretty well with controlling mood, mostly with anxiety, mostly with some of the other problems. We can do pretty well, but we're not perfect. And that's why there's tons and tons of research ongoing, because we're not doing as well as we could. So I always ask people this: what is the side effect of not trying the medication? So we know what the side effects could be with the medication, and we look at numbers, maybe 4, 5, 10, things like an impulse control disorder, 15, 16%, roughly speaking. So we can say, well, the side effect of taking this medication may include something as great as a 15% chance that I'll have an impulse control disorder. But the side effect of not taking the medication is a 100% chance I will have the problems I'm here with. And we do have to bear in mind that balance. Now, what is the problem that you present with? Is it bad enough? Whatever that 100% trouble is it bad enough to warrant that 16% risk or 5% risk? If you have symptoms that don't impact your quality of life, we don't necessarily have to treat those symptoms either. And that's an important thing to remember. But I do like to ask people, what's the side effect of not trying? If you're coming in and saying, I can't write, I can't walk, I can't dress, I can't feed myself, I can't wash my hair, I can't shave. Okay, that's the side effect of not trying. Now, where do we go from there? And I believe, I'll terminate this with a couple other slides, improving function and quality of life is the goal. That's what we're trying to do: improve function, improve quality of life. Better treatments can reduce disease progression, better treatments that can reduce disease progression. That's the Holy Grail. This is what we're looking for. That's what we want. We want to be able to identify what can we do to change the course of this disease process, stop it, I don't know about reverse it. Reverse it's tough. Brain's a complicated place. But can we stop it from getting worse? We don't have anything like that yet, but tremendous amount of work being done in that region. And I think that is, in fact, all I have to say.